Welcome to today's webinar on an introduction to microcosting for public health interventions. Today's webinar is a part of a fall webinar series hosted by RAISE and NASTAD. So this is our second webinar in the webinar series. We will be hosting our final webinar on December 17th, which will focus on a case study of Washington State Health Departments and their efforts to estimate costs of STD program services. For those of you who may not be familiar with RAISE and NASTAD, the University of Washington has a NIH-funded Research Alliance and Implementation Science to End HIV, or RAISE Hub. So this webinar series is a part of their work in collaboration with NASTAD. NASTAD is the National Association of State and Territorial AIDS Directors. We are the CDC-funded capacity building assistance provider currently for EHE and other health departments receiving PS 2447 funding. And through this collaboration, our aim is to strengthen implementation science through public health at state and local EHE health departments. So we do these through several different activities, including webinars on relevant topics. We also do tailored health department consultations, and we'll be putting in some information on how you can request a consultation if you're interested in meeting with the RAISE team. We also do site visits and reverse site visits and host a evaluating EHE implementation workshop where folks can learn how to use implementation science to evaluate their EHE programming. So today's talk will be facilitated by our guest speaker, Monisha Sharma. She is an associate professor in the Department of Global Health at the University of Washington, and we'll be talking about how microcosting can be used by public health departments. So over to you, Dr. Sharma.
Yeah, thanks for joining today. I'm going to be talking a bit about microcosting and how it's used for public health interventions. So I wanted to start by thinking about why we conduct a costing of health interventions. This can be helpful for budget planning. So if you're trying to understand how you should structure your budget for the following years, you can also understand intervention affordability. So you can look at the cost of this intervention compared to others that you might be interested in implementing, or to the size of your budget overall to see how this would impact it. You can also evaluate efficiency, and this is mostly economic evaluations like cost effectiveness analyses, where you're trying to understand the cost per health unit of benefit. So cost per HIV case averted, or in that kind of vein with a health benefit as the denominator. Costing can also provide transparency for funders and policymakers, just understanding what's going into different health interventions. And you can also compare options and scale up scenarios for the same intervention. So you can say for HIV testing, should it be implemented through drop-in clinics or through mobile vans? And you can look at the different costs associated with different scale up. You can also use costing to identify areas of inefficiency. So if you're doing a microcosting and you can see that you're spending a lot of money in one area, you could interrogate that and see if you can create efficiencies, reduce paper forms, anything that would increase or reduce the cost and kind of increase your affordability of that intervention. And you can also look at actual versus ideal costs. So you do have a budget when you go into implementing an intervention, and that's kind of your projections of what you're going to spend. But collecting the actual costs will help you get a better idea of the real world kind of costs associated with your intervention. Also, when you're doing a costing, it's important to think about the perspective that you'll be using to collect the costs. So the payer perspective is the person who's paying for the health intervention. And so this could be the health department, the funders, or any kind of donation. So that's who is kind kind of putting in money for the health intervention. And then the broader societal perspective includes both the payer and then any costs of the clients for receiving care. So clients traveling and waiting to receive an intervention, cost of the bus, cost of missing work. And that is usually done for an economic evaluation. So if you're just looking at what is the program costs associated with my intervention, you would likely be using a payer perspective. And if it within that health department, if you're only responsible for paying for certain goods, you might use a limited payer perspective. So you only want to understand what you have to pay to implement this intervention. You also want to think about how your costs will be used. So if you're budget planning for continuing an intervention, so you have an intervention already that the health department is running, and you want to know what's the cost of continuing this intervention, you would look at just the continuation cost, so year 2+ after it's implemented. What's the cost of running this in the future? If you're interested in understanding the full costs because you're going to provide this information to another health department or a clinic who might be interested in adopting this intervention, you'll want to include the year 1 startup costs as well as the continuation costs. So the startup costs are higher in year 1 because you're hiring, training, buying equipment, and then year 2 gets cheaper. So depending on where you are in your intervention and what the goals are of your costing, that might change what you're interested in collecting. And then, of course, if you have a cost effectiveness analysis, you would have to be much more detailed about collecting your costs and collect economic in addition to financial costs. So some considerations for a cost analysis is understanding your time horizon that you want to capture your costs. And usually we do annual costs. So we'll look at what's the cost of running this intervention for a year. You can also look at costs per unit of effectiveness, for example, like a cost per participant reach. So how much does it cost to reach one client with PrEP navigation services? So that's the annual cost of the intervention divided by the number of people reached. Or if you want to drill down more, you can say, what is the cost of the people not only reached, but the ones that are successfully linked to PrEP? And so that would be the total annual cost divided by the number of people successfully linked. So if you want to understand how much you're spending as a health department as a unit of some kind of outcome metric, you can say, here's how much we spend to get one client on PrEP. Another thing that you would want to decide when you're doing a costing or before you start the data collection is if you're collecting financial or economic costs. And I suspect for most of you, if you want to understand the budget impact or the affordability of your interventions, you'll be using financial costs. So the financial costs are the actual amount that you pay in order to implement your intervention. So it doesn't always represent the economic costs, which is all the resources that go into it, including the ones that you didn't have to pay for. So the economic cost is the total value of that intervention. So often interventions have things that are donated from another project that you're pulling in, or volunteers that are working on an intervention, and the cost of that financially is zero, but in terms of the actual value of that intervention, you would include everything, all of the resources that you're using, because you want to understand kind of the full picture of what's going into that intervention. And that's because if you have an intervention that has a lot of donated goods, it could look really cheap. The financial cost would be cheap, but you're actually using a lot of resources, and the economic costs help capture that because you're getting the value of everything, and those services could be going to another intervention. So because you're using them for free, it still doesn't mean that there's not some kind of opportunity cost associated with that kind of decision. So if you're interested in what is the amount of money that will hit my budget when I'm implementing this health intervention, you're probably going to want to collect financial costs. So what are you actually spending? Not what is the value. If you're getting something at a discount, you put in that number at a discount because you're only looking at what you're spending. So it's more practical and pragmatic in terms of planning for a program. But if you're looking at program efficiency, and if you want to say, okay, what is all the resources that are going into this intervention? Because even if they're free, they could be going somewhere else. Like, what is this intervention using in terms of supplies and equipment? Then you would collect economic costs. And the economic costs for a intervention with a lot of free items is much higher. So in terms of financial costs, as I mentioned, intervention costs are usually higher in year one. So if you're planning a budget for implementing a health intervention, often the year one costs will be much greater. So you might have to hire and train staff, you might have to buy equipment, computers, etc. And that all needs to be kind of budgeted in order to run the intervention. But as I mentioned, if you want to understand how to continue an intervention, you would estimate the costs, all the variable costs that go into having that run once it's implemented. And in terms of the financial costs, you'll want to think about what you're actually what is the system, the health system that you're implementing this intervention in. So if in order to run, a new prep navigation service, you have to hire prep navigators and then you have to train them to do the intervention, then those costs would be included in year one. You have to include the cost of advertising, interviewing, shortlisting, all of that, and then training, and that can be substantial. But if your program is using previously hired staff, so you're implementing prep navigation services in an organization that already has those people that can do that job, but you would have to train them for that, then you would only include the costs of training that staff. And then obviously if people are already hired and already trained, then you wouldn't include these costs. You would just include the costs of continuing that intervention. So it's helpful to kind of ask all these questions beforehand so it can help hone down on what exactly you'll need to collect, and you're not collecting more than you would need to answer your question. So the steps involved in costing is first to identify all of the resources. So who are the staff providing the care, and what are the activities that they're conducting within the intervention? And where is the intervention delivered? Is it in a clinic? Is it in the community? And then once we know what the resources are that are being used, we want to quantify and measure the amount of each resource used. So you're using staff, but how much staff time is required to perform this intervention? And how many gloves or screening tests or other supplies and equipment are used? And then once you have the quantity of what's used, you will want to estimate the unit cost of each resource. So what's the salary cost for the staff providing the intervention based on the time that they're spending? What's the cost of the gloves? And then you multiply the quantity used by the unit cost to get the total cost of the intervention. So in terms of approaches for measuring costs, there's a wide range, and we can use microcosting, which is something that we often do, which is you quantify the unit cost of every single input that goes into an intervention. And it's the most precise, but it's also the most resource intensive because you have to go through and account for all of the activities of an intervention and then all of the resources to run those activities. And on the other side of the spectrum, we have gross costing or top-down costing. And here we just take the total cost of the intervention. So you just see what is hitting your budget and divide it by the number of participants seen and say, this is the total cost. And so we get this lump sum per person seen, but you're not really drilling down into what are the exact things going into each client visit. So you get a estimate, and if that's kind of sufficient for your question, then you can just take a total sum of everything that was spent on prep navigation in 1 year and then divide it by the number people seen, and that's the cost per person. But you wouldn't get, for each person, how much time does the prep navigator spend, or what are the supplies going into that person? So, and then how can we modify those to make it cheaper? And generally, when we conduct a costing, we use a mix of these approaches. So we'll often do a micro costing for personnel costs and supplies, and we could do a gross costing for other kind of healthcare costs. And so if we are conducting a micro costing, we often will collect those costs from a program implementation of an intervention. So if you want to understand the cost of an intervention, it has to be running currently, and then you can collect those costs from the actual program that's running. So you can often take the costs and split them into kind of mutually exclusive categories. And so here I've specified some example categories that are commonly used in a typical health intervention. So by taking your health intervention and splitting it into these categories, you can more easily define the costs that are associated with each area. So you can say, for personnel, who are the staff working on the intervention, and then equipment, what is being used in terms of computers and other supplies. And then you can, as long as everything is accounted for somewhere, these kind of categories can be arbitrary, and you can split them in a way that makes sense to you. So one type of costing is activity-based microcosting, and that's a common way to do a costing. And so here you microcost each set of program activities. So the first thing you do is you take your intervention and you divide it into activities. And then you identify and measure the resources used in each of those activities. So if you had a community HIV testing intervention, you could split that into categories like community mobilization and outreach, staff hiring and training, and HIV testing. And then for each of these categories, you can say, what are the resources that I need to perform these activities? And one thing that's useful when you're doing a microcosting is you can actually create an intervention flow map. And this can make it easier to make sure you have all the activities and you have all of the categories and the resources associated with your intervention. So here, this is pretty detailed about just one activity. And so this is an adolescent HIV care intervention. And you can say, okay, a person enters, they go to triage, and then they see a clinician or a nurse. So what is the nurse salary time? How long are they spending? What are the resources that they're using for the assessment? And then you go to HIV adherence counseling. Who is that done by? Is that an HIV adherence counselor? And what materials are they using? And then what are the supplies and equipment needed for the blood draw? And then you go through till the end, and you can make sure that you have all of the pieces that make up the costs for your intervention. And so in terms of data sources for a costing, you can often use expense reports. So from the accountant, what is being spent on the intervention. You can also use published unit cost estimates. So that might not be as relevant if you're just doing a financial costing of what you're spending, but if you're if you want to understand the full payer perspective of PrEP navigation services, you would want to cost the PrEP medication, and that maybe you could use a published unit cost. You can also do time and motion observations to understand the time spent by the staff in each aspect of the intervention. And you can also do staff interviews, and this is really helpful to understand from their perspective, what are the resources being used in an intervention, and and how long are they spending on each aspect of the intervention. So in terms of measuring and categorizing costs, you can also classify them into fixed versus variable. So fixed costs generally remain the same, no matter how many people are reached with the intervention. So if you are going to start a HIV testing intervention, you'll need file cabinets, computers, printers, and vehicles if it's an outreach intervention. And you'll have to buy these things even if you see 10 patients or 100 patients. That cost is not going to change. And then you have variable costs, which then increase with the number of people that are reached with the intervention. So HIV testing kits, gloves, reminder cards for appointments or staff time. The more people you're reaching with the intervention, the more staff time is being used, and transport and fuel costs. So for these costs, as you're collecting them, you'll multiply them by the number of people reached with your intervention, versus the fixed costs are just going to be written as kind of the same regardless. And then for financial costing, you'll want to understand which fixed costs are already available to use and what has to be newly purchased for the intervention. So I would assume with most health departments, if you're trying to understand what do I have to budget to implement this intervention, if there are already computers there that you'll be using, if there's already printers, then you don't have to buy those. You can just use what's available. But if you do have to buy new file cabinets to keep participant records, then those would be the new costs. So you would go through and cost everything that is kind of in addition to what's already there. So like an incremental cost to implement the intervention. And then just all unit costs will be variable in the long term or at a larger scale. So once you're estimating, the client volume, if you want to know what's the cost of like tripling the client volume, at that point you will have to buy more file cabinets or computers. Like these fixed costs are fixed up to a certain point, and then you would have to get more of them in order to scale the intervention up to a higher level. And these costs can also be classified into capital versus recurrent. So capital costs are generally those fixed costs, like computers, vehicles, and they're bought at the start of the program. So they're bought in year one, but they last for more than 1 year. They can be used for 5 to 10 years. And then recurrent costs are the ones that you have to buy regularly. So printer paper, office supplies, pens, those are the ones that will increase with client volume and that you are using up. And so for capital costs, if you are doing an economic evaluation, we often convert those into recurrent costs by spreading them over the time period that they're used. So if you have a computer and you're going to use it for 5 years, you convert it to 1/5 of that cost over 5 years. And that's and there's a formula to do that. But that's more if you're doing an economic evaluation. And if you're just doing kind of more of a practical financial accounting, then you wouldn't need to do that. You could separate year one and year two costs. So year one, you would hire staff, you would buy computers and file cabinets, and then those would be continued to be used. So for at least 5 years before you would have to do them again. So you can separate out and kind of understand what's the cost of starting and what's the cost of continuing a health intervention. So in terms of capturing personnel time involved in health interventions, this can be kind of a substantial cost. And so it's important to really understand what is the personnel time involved in implementing a service. So for example, if you wanted to understand a PrEP navigator's personnel costs, you would take their gross salary times the time needed to perform that intervention. So just as an illustrative example, if a salary is 60K and benefits associated with that are 15K, then in order to fund a PrEP navigator, you would have to set aside 75K. And then the hours worked per day, we can assume 7 with a lunch break, and these will all change depending on your personal kind of situation. This is just illustrative. We would maybe assume in this case that in this health department, they work 5 days a week, but you subtract from the 52 work weeks the vacation time. So 20 vacation days, 13 public holidays, and sick days. So then you get a total number of days that this individual will be working per year. And then you can calculate a salary per hour. So that's the annual salary divided by the hours you're working in that year. And so that's the days worked per year times the hours worked per year is per day is the hours worked per year. And then you divide it by the total salary. And I have that kind of on the bottom left. And so then when you get that, you can get the salary per hour. And then if you divide that further, you can get the salary per minute. So this individual costs 82 cents per minute. Um, and then if you want to understand what is the time cost needed for prep navigation, you would attach this cost to the activity costs that you've already kind of identified. So here you have an activity that's outreach and identification. So going out and finding individuals in the community that might be eligible for prep. And that is done by the staff member of that's done by the prep navigator. And it takes 60 minutes. And their salary per minute is 82 cents. So the cost for that activity is $49.20. And then you can go through and do this for every step of prep navigation. So step 2, intake and eligibility screening, that's done by a linkage coordinator, and that takes 45 minutes, and their salary per minute is 69 cents. So the cost for that activity is the 69 cents times 45 minutes, so $31 an hour. And then navigation and linkage to provider. Step 4, insurance and medication assistance, benefits enrollment. You could assume that that might be done by a benefits specialist and they have a different salary. So you multiply that by the time that they're spending. Follow up and adherence, and maybe there's a case manager doing data collection, and that takes about 15 minutes per client. So overall, we're finding for this kind of flow, the total personnel costs for one client is $154.75. And at these different steps, you can also assign supplies and supply costs. So you could say the outreach and identification, you're handing out brochures and you're giving away incentives, and that you can estimate the cost of that. And intake and eligibility screening, you have to do an HIV test and you need gloves and a test kit. And so you can assign supplies to this, and then you can assign costs to those supplies. So how do we estimate the time needed for intervention activity? So on the previous slide, we saw, certain aspects of prep navigation take 30 minutes or 45 minutes, and where do those estimates come from? So you could do qualitative interviews or surveys with staff. So you could interview prep navigators, case managers, benefit specialists, and say, okay, how long does one's outreach service cost, or how long does it take you, and how long does it take to fill out this paperwork? And you could use the estimates that they're giving you to understand the time costs. And that's the cheapest and the least resource intensive, but it's also the least precise, because you could not have a good sense of how long you spend. And if people ask you how long you spend on different aspects of your job, you might have more or less degrees of certainty around what it actually takes. So the most objective way to do it, but also the most resource intensive, is time and motion observation. So this is watching and timing individuals as they perform the intervention. And in general, in the published literature, this is a common way of understanding the time costs associated with an intervention. So here in this published analysis, 42% of the studies use this continuous observation. So somebody's watching as different aspects of an intervention continue. But other ways that you can do it is activity tracking. So you could say to the prep navigators, can you write down when you start the outreach, when you stop the outreach, and then when you start eligibility screening and stop, and then you take those numbers and then you can calculate the time used. And that is asking a bit more of the staff, but it can be cheaper because then you're not having somebody that you're paying to watch all of these activities and then time them. There's also automatic timestamps. Sometimes when somebody opens up an eligibility screening in access, it could say when it was opened and when it was closed, and you could use that to estimate time costs. And often you use a combination of these methods. So some you can do some time in motion, and other things you might have to get by self-report. And just to define time in motion, this is the analysis of time spent in different motions of a job. So it was originally used in industries to identify inefficiencies. So replacing paper forms with electronic forms to improve workflow. You can remove bottlenecks. You can see that at one point there's not enough of one type of staff, so people are waiting, and you can address that. And so it basically is used to understand and quantify the impact of a health intervention on staff workflow and patient experience. So as we showed with prep navigation, this is the first steps of time in motion is to divide the intervention into activities. So a prep intervention can be divided into clinic visit for prep initiation, follow-up, lab processing. And within these activities, you can even get more granular. And you may or may not want to do this. It is more resource intensive if you're asking people to write it down and self-report, but you could say, okay, within the prep initiation activity, how long does each sub-task take? How long does it take to do an HIV test or to do risk assessment and then adherence counseling and prescription? And then you time each of you either time the whole activity or time each part, and then observe multiple activities to assess the mean and the variability in the activity. So just to mention some caveats, you often want to just estimate active time. So if it takes 30 minutes to process a lab sample, but the person is not, the lab tech is not just waiting there watching the machine go, they're doing other things. So you only want to count the time that they're loading up the machine and then the time when they're taking things out. There's often multitasking happening, so it might be hard to understand how much time you're spending on one thing when there's like kind of a couple of things going on. There could be task fragmentation, so you could start one prep navigation activity and then get interrupted and be pulled into a different intervention activity for something else and then come back. And then there's just variability. And so everybody's going to do these services differently. So if you follow one prep navigator and another, one person could just spend a lot of time on counseling and it takes like an hour, and another person could just do it quicker and it takes 20 minutes. And so no matter how many people you observe, once this is rolled out somewhere else, those numbers are going to change because people have different work styles. And so there's no set sample size for time in motion. You just kind of like qualitative data collection. You just watch those parts of an intervention until you feel like you've reached saturation of information. It helps to vary the staff that you're following, so you get more of a broad understanding of the intervention, different days or time of year. So sometimes during the holidays, things can get slower and things take longer, or on Mondays, things are busy versus Fridays. So you kind of want to think about all these things to try to get an average amount of time spent. And just some practical tips, because we've run into this when we are doing time and motion observation. We want to make sure that if you're getting an external person in to watch staff as they conduct their job, that you want to let them know that you're just timing this to understand resources needed for an intervention. You're not, evaluating their efficiency or reporting things to their supervisors. It can feel a little disconcerting to have somebody follow you around at work and write down what you're doing and when you're doing it, and you might feel kind of like you might change your behavior. You might think that they're kind of watching you to report to management, and so you just want to make sure that that's not that they know that's not the case. So it helps to be discreet, have a stopwatch, and then try to avoid that effect of people just your presence changing the behavior and changing the flow of the intervention. And these are just some example data collection tools. So if someone is observing or if someone's self-reporting, you can just have a really basic paper document where they write down, start of outreach, time start, time stop, start of adherence counseling. And then this can either be written down by the individual watching, or it could be self-report. And they can use these to note interruptions. They could say started, I stopped because I was interrupted, and then I restarted, and then you can kind of add these time start and stops and then get an overall estimate. If it's easier, you can build an Access or a REDCap form to collect this data, and people can just enter it in. You can create predefined categories, so they can just click, adherence, activity follow-up, so they don't have to write it. So there are ways to make this more efficient and less burdensome for staff. So in terms of costing supplies and equipment, it helps to have standard assumptions and in collecting and reporting this information. And these may not apply as much because it's for economic evaluations, but if you buy a computer or a vehicle, we often use standard assumptions that you can use these for 5 to 7 years before you would have to buy a new one. Or once you hire staff and train them, you'll eventually have turnover and you'll have to do it again in 5 to 7 years. We often assume a certain amount of wastage of supplies, so not every single glove that you buy is going to be used. Or some, HIV test kits could be dropped or expire. And then this is more for an economic evaluation, but if you have these overhead costs that are, building and internet that the intervention is using, but other interventions are also using them, they can be allocated by the percentage of time used for that intervention. And so, for example, for the building, if it's in a clinic, you could say the percentage of floor space needed for that intervention for the time you're using it. And you could allocate staff time and equipment. So if you have a lab equipment and it's being used by multiple interventions, you might say, okay, well, this intervention uses a fifth of those costs. And these are all mainly for economic evaluation. So if you're just understanding the financial costs, the building is already there, it's paid for. So when you add prep navigation services, you're not paying more money for the building. This is just if you want to understand all of the resources going into the intervention. And so often when you're collecting this data, we use Excel templates, and then you can put in the item, the number, the cost, and then it will add up to the total. And I have a blank Excel template that I've used for previous costings that I can share with you. And it's broken down by activity and what's used for each activity. And these will likely change as you do the costing. You'll find that you'll need to tailor any templates that you're using. It might be good to create a protocol before you start, so you can identify important costs and find out who you might need to talk to understand the resource use of the intervention. And then if you're interviewing staff about resource use, it helps to kind of ask open-ended questions, figuring out what costs you might be missing, because if you're only asking about certain activities, there may be another activity that they're doing for the intervention that you haven't brought up. And it's helpful to also ask these to various staff to understand what is the variation. So some people might have a set of activities that they do for HIV outreach testing, and then another person might have it slightly different. So you want to understand on average, how is this done? For startup costs, it's helpful to talk to the HR managers and anyone else that's involved in that hiring, and then understand that the time and money spent, starting from advertising a position, interviewing, and then offering, and then the time spent by each staff member. So here I have just a snapshot of one of my costing spreadsheets where this is a partner services intervention, and we hired health advisors, field coordinators, data managers. So this was an RCT, and then office assistants. And so we have how long did it take to interview for these positions, who did the interview, and the positions the number that were hired. And then these are the time costs. So the time that each of these individuals spent times their salary. And then we have a cost per person hired. Um, Similarly with training, once individuals were hired, they needed to be trained. So who did the training? How many hours did that take? And what was the salary cost of the person conducting that training? So often in health departments, there might be a senior staff that spends several days training somebody. And so there is a cost associated with that. And then another startup cost might be community outreach. So if you're entering into a new community or you're offering a new service, you want to advertise to increase demand, meet with community leaders to obtain buy-in so they can then promote your intervention. And this might happen just at the start of the intervention, or it might be an ongoing kind of activity. So maybe year one, there's like a big community outreach, but then in the future, you'll have to continue doing these at a smaller scale. So you'll have to include those costs as well. And so this is just an example of these are for prep navigation. If you were to say, what are all the costs associated with community outreach? You might have prep educational pamphlets, posters, branded giveaway, and then pop-up displays. So you would want to understand everything that goes into it from time costs to resource costs. And then in terms of supplies, this is just what my spreadsheet looked like. And it's important when you're itemizing this to link it to your client volume. So you probably get a unit cost for like 100 gloves. And then you say, okay, well, then what's the cost of one glove and how many people am I reaching? And that's the total annual cost. And this is for overhead. So you may not be doing this if you're doing economic costs, but here we would get all of the overhead costs. So the clinic space, water, electricity, internet, and then what percentage of it is used for the intervention. And so this wasn't really allocated. This intervention the whole space was being used for partner services. So aside from internet, which was being shared by another program, 100% of these costs went to APS. And so when you're kind of finished with your costing, you could get estimates that look like this. So this is the cost that we calculated for partner services, and we divided it by if the partner was HIV negative or positive, because when someone was diagnosed positive, there was increased supplies in terms of confirmatory testing and then more counseling. So here we can see not only what is the total cost of the intervention, but what are the costs that go into it and what are the cost drivers. And you can see here that personnel costs are really the biggest cost driver. It's a very resource intensive intervention in terms of people's time going out and trying to reach partners, calling them multiple times and getting them to be screened. So some data collection challenges might be variation in staff time and resource use among staff, a limited time of observation. You may only have a couple weeks to do this time and motion if you're doing it, and it could be during, a holiday season or a time that's not reflective of the overall year. There's also staff turnover. So if you're trying to understand what it costs to hire a prep navigator and the HR person has turned over, then you have to kind of piece together what that might have looked like. And there's often missing costs. You really try to ask about every aspect of the intervention, but there's probably something that you're missing. So the pros of doing a microcosting is that it provides this kind of detailed assessment of a program. What are the cost drivers? Where are the areas of inefficiency? You can change around the inputs and see how the costs will change. So what if you task shifted to someone that was paid a lower salary? How would the cost change? It is time intensive, and especially for time and motion, and then you can often underestimate costs because you'll miss something. So in terms of simplifying it, it's often easier to collect the financial costs because then you're just collecting all the things that you're actually paying for. You know how much you're actually paying for them. It's cheaper to do staff surveys or staff interviews about their time and resource use, or ask them to track their time. So every time they start an activity, stop an activity, they can track it. If you do time and motion observations, that can be more resource intensive. And you can focus on the most influential costs. So you can spend a lot of time drilling down, what's the cost of uh, this cotton ball that I'm using, but it's so minor that it's not going to make a difference in the cost. So really spending your time on the most influential costs it is helpful. Okay, and then with that, I'll take any questions.